Hello there students, this is Kamran Bhopal and I'm here again with another session for the ST3 Urology National Training Interviews. We're going to go over some questions on the lower urinary tract symptoms scenario, and I've already done the history for this, which you can look at in my previous videos. One of the questions that they may ask is how you would examine this patient. You can tell them about abdominal examination, palpable bladder, palpable kidneys or flank tenderness, genital examination, and also looking for any tight phimosis or meatal stenosis, DRE to look for size, smoothness or cragginess or tenderness of the prostate, and then neurological examination to look for perianal sensation and anal tone, also power sensation and reflexes. Then the investigations you would organize in lower urinary tract symptoms. This is, keep in mind, a BPH scenario in a male, IPSS score and a bladder diary, urine dip, MSU, microscopy and culture, a flow test and a post-void residual, bloods including kidney function and PSA. Then you can consider an ultrasound KUB in select cases where you felt a palpable bladder to rule out high pressure chronic retention, etc. TRUS or transrectal ultrasound can be used to assess the size of the prostate, and flexible cystoscopy can be done in flow tests which are directing towards a urethral stricture rather than a BPH scenario. Urodynamics can be considered on a case-to-case basis in which it is unclear and the patient's got mixed symptoms and the flow test is equivocal. Then there's a question about when to consider urodynamics. So you should consider urodynamics when there has been previous unsuccessful invasive treatment for lower urinary tract symptoms, patients who cannot void greater than 150 mils, bothersome voiding LUTS with post-void residual greater than 300 mils, patients with voiding LUTS with age greater than 80 years or less than 50 years. And you can also consider urodynamics when there's an equivocal flow test with a Qmax of greater than 10 mils per second with LUTS, and also patients who've got neurological disease. And this is EAU guidelines. You can have a look on the EAU guidelines as well, and it's the same. Then treatments of BPH and going in that direction, you can do conservative, which is watchful waiting, lifestyle advice, and phytotherapy. I mean, you can say in phytotherapy, you've got saw palmetto and riboflavin extract if you want to go in that direction. I did feel like saying urethral milking and other things wasn't necessary, but I made some notes separately to say, okay, if there are storage symptoms, I would say ask the patient for better hydration, reduced caffeine, reduced alcohol and fizzy drinks, and bladder training. For voiding symptoms, if the patient has post-micturition dribble, I would ask for urethral milking and phytotherapy, saw palmetto and riboflavin extract. And if there's any stress incontinence, I would ask for pelvic floor exercises, etc. Now, this is a very generic answer, but if the scenario is towards BPH, then go for more obstructive treatments rather than other stress incontinence and storage symptom treatments. Medical management, you've got monotherapy and dual therapy. So monotherapy is with alpha-1 blockers, damsulacin or alfuzacin, which relaxes the bladder, neck and prostatic urethral muscles. And they can sometimes actually ask you the contraindications or side effects. So dizziness and low blood pressure and dry ejaculation. So then dual therapy is finasteride, which is 5-alpha reductase inhibitor with an alpha blocker, and basically reduce dihydrotestosterone levels, because 5-alpha reductase converts the testosterone into dihydrotestosterone. So reduced dihydrotestosterone level stops prostatic growth but can cause loss of libido and erectile dysfunction. I don't think they're going to go into the MTOPS RCT and combat RCT study, but it's good to just know about them, and they suggest that combination therapy with finasteride and damsulacin have better outcomes than monotherapy for moderate to severe LUTS. Then if they go on and say, okay, the patient has bladder overactivity, what are your suggestions? In that case, you can use antimuscarinics as a first line, also known as anticholinergics such as solifenacin, tolterodine, oxybutynin, and then you can use as a second line beta-3 agonists such as mirabegron. If they ask about doses, mirabegron is 50 milligrams a day, solifenacin is 5 milligrams once daily, but that can be increased to 10 milligrams once daily. Surgical management, talking about BPH over here, we'll come to the other types of LUTS later down the line in a separate station of stress and urge incontinence and overactive bladder, etc. Surgical management of BPH. Now there's different ways of formulating it, but you can say if the prostate volume is less than 35 cc, I would go for a bladder neck incision, or TUIP, transurethral incision of prostate. If the prostate volume is between 30 and 80 cc, in my trust we would normally go for a TURP. If the prostate volume is greater than 80 cc, we would go for a HOLEP, or a holmium laser enucleation of the prostate. Then you can mention other considerations are green light laser or PVP for patients on anticoagulants, Resume for people who want to retain their sexual function, Urolift for people who are not fit for general anesthetic, and there are newer techniques such as aquablation also coming in certain centers. So this also covers all bits, but also tells that you have been in theaters, you know about different bladder outlet obstruction techniques, etc. Then they can ask you about how you would consent for TURP. We're not going to go into that. You can have a look up on the BAUS website. Then they may ask you about the TURP procedure, how it is done. Again, I would suggest go and read through the FRCS Fiber book, but when I'm going to go to do the clinical skill stations, I would probably go through the technique as well. We'll see you next time with further questions with other stations. I wish you all the best and hope you all get an NTN.